Hello, Planet Earth. Welcome to Lilia's Weekly Wednesdays, and thank you for joining us. Who am I? I'm Lilia. My pronouns are she and hers, and please do tell us your name, your pronouns, and where you're from in the comments below. I created the Facialteam Facebook about 8 years ago this spring, and I've always been dedicated to the trans community, and I've always considered myself sort of as a patient advocate. So that's kind of why I've started doing these lives. Researching gender identity nowadays is often overwhelming for all of you who are transitioning. And so these live streams are a way to communicate important information to you, our followers, and to provide a beacon where your questions regarding transition could be answered. So today I am very honored to have a special guest here, Dr. Will Powers.
Hi.
And Dr. Simon of Facialteam. Dr. Will Powers is a family physician from Detroit, and Dr. Simon is an FFS specialist for Facialteam. So it's a real pleasure to have both of you here today.
Thank you for having me.
Thank you so much.
I'm sure that we're going to have a very interesting discussion. So to those listening to the live now, again, please tell us where you're from. And be sure to let us know what your questions are down in the comments, and we'll be checking those and replying along the way. So don't be afraid to ask us questions. Now, I would like to start with a little bit of an introduction for both of our doctors here. So first, let me introduce Dr. Will Powers. He is a board-certified family physician offering whole life care. You don't hear that too often, whole life care.
Cradle to the grave.
Educated in the University of Pittsburgh with a bachelor's in science in neuroscience in 2007, followed by a year of university in Madrid to complete a master's in Spanish. And lastly, medical school at Lake Erie College of Osteopathic Medicine. Most recently, he founded Powers Family Medicine, which is, quote, a new kind of family practice that is truly welcoming to everyone. And I love that phrase. The practice was founded in Detroit just over a year ago, and most interestingly, he has 143 Facebook reviews. I've never seen so many reviews on a family practice site, and 5 stars. That's incredible. And 98 Google reviews, and also 5 stars. So that's really remarkable, I have to say. And it's only in a little more over than 3 years of practice. He's known for his innovative online portal to attend patients with, which I checked out yesterday, very interesting. And it's for video teleconferencing, and he's able to provide services in a timely and orderly manner through that platform. So in order to continue to meet an excessively high demand, which he has all over the world, people asking for his services, he has never closed during the pandemic. He operates as well as a COVID-19 antibody and antigen testing center. So you may have seen photos of him gearing up in his full biohazard suit every Tuesday and Thursday to offer testing to his community. On a more personal note, Dr. Powers is an avid outdoorsman. He enjoys cosplay as well. Steampunk, I don't know what that is. You have to tell me. He has had Guinness Book of World Records exotic cats and has Savannah cats trained as emotional support animals in his clinic every day. And he has them there with him today. He is an avid gamer and has an arcade in the lobby and gaming consoles in all his exam rooms. And he's also got a penchant for candy, which is his one and only vice, apparently. So in his medical career, he's taken a special interest to rare and difficult to diagnose conditions, and importantly, welcomes people of all walks of life to his practice and promotes a healthcare environment free of discrimination. He's a certified HIV specialist and was one of the first clinics in Michigan to offer COVID testing, weeks ahead of the state government. He's especially popular and well known for his Powers method to HRT. So welcome, Dr. Powers.
That was, I think, the most elaborate introduction anyone's ever done for me in my whole life. I feel kind of weird.
But was very thorough. I love it.
I feel welcome. I very much feel welcome.
I wanted to sing your praises, so Dr. Simon, you can go now.
Good. Thank you, Lilia.
Of course, now I would also like to introduce Dr. Simon. For those of you who are just beginning and may not have heard of Facialteam, and Dr. Simon is one of the founders and directors, along with his colleague, Dr. Luis Capitan. They began Facialteam in 2010 in Marbella, Spain. A decade later, their team has grown to an integrated group of 50 professionals with surgeons, anesthesiologists, dermatologists, nurses, psychologists, physical therapists, acupuncturists, coordinators, live streamers, all dedicated to facial gender patients. Under Dr. Simon's direction, Facialteam's achievements, which I would also like to sing his praises a little bit. On the clinical side, over 3,000 surgical procedures have been performed and 8,000 patients have been benefited from free consultations and orientations on 4 continents in the last decade. In terms of activity within the medical community, Facialteam has award-winning research with 18 scientific articles in leading journals, academic publications which share outcomes of their experience, a unique training program launched in 2018 to train future FFS specialists, and has conducted CAD lab training workshops for professionals at leading medical institutions such as Johns Hopkins University, Mount Sinai, and the annual meeting of the American Society of Plastic Surgery. Regarding some technical innovations, Facialteam has developed both new approaches to FFS as well as working to improve ultrasonic instruments and the implementation of new software employed in 3D surgical planning of osteotomies. This all translates to more predictable results and safety for patients. Facialteam is also notably on the work group for the WPATH's 8th edition of their Standards of Care document. It's the equivalent to the best practices of the World Health Organization's basic document on best practices, which informs the worldwide transgender and gender nonconforming provider network, and is currently the sole reference in trans, non-binary, and intersex healthcare for medical insurance companies. So very important document that's influential. So that's quite a presentation.
Wow.
That was cooler than mine.
I don't think so. I would like to, but you have cats. I love the cats. I will bring my dog very soon because you're showing your cat. I'm going to bring my dog.
I'm jealous of the cats. I want cats.
They're good boys.
In the clinic. Cats, candy, and games.
Yeah.
So I've been authorized to interrupt. I just want to let our viewers know I'm not being rude. I've been told to interrupt because I do need to in order to let the doctors know what your questions are. So again, please write your questions down below in the comments, okay?
Perfect.
So we'll start off just, I guess, a basic theme, no? Right now, healthcare for trans, non-binary, intersex, and other gender non-conforming patients. And we want to put a highlight on the relationship between HRT and FFS in our discussion today. So as a little icebreaker, I'd like to first ask both of you to comment a little bit about your thoughts on the global situation and how you think trans people are experiencing this during the pandemic.
Dr. Powers, please.
As you wish. So I guess in my own clinical practice, what I have seen I guess I've been doing this for 7 years now. I've been treating transgender patients, probably around somewhere between 1,500 and 2,000. There's like this continuum of socioeconomic status with transgender people. There are people who present very early that have very severe gender dysphoria. And they commonly, like, the joke is too trans to function, but literally, like, they are incredibly transgender. They have very powerful gender dysphoria, and it does not matter to them what the socioeconomic cost is of transitioning. And so if they lose their job, they don't care. Like, they end up losing their family, friends, they lose a lot, and it's awful, but they do it because it's such a big deal to them. Then there's this middle class so there's a lot of them. Then there's this poorly represented middle class where the people who have gender dysphoria but are fighting it down so that they can keep their spouse and their job and their middle class life. And then there's this like spike I see again, where when someone has gotten wealthy enough that they don't care, that they're willing to take the social price of transitioning and doing everything else. And it's very strange because the socioeconomic gap in my patients, I either have very wealthy trans patients or I have very poor trans patients. There's very little in the middle. And as we all know, the economic downturn from this has been brutal. So when you have a large 401k and a savings, if your business, temporarily suspends or whatever, it's not the end of the world. But when you're living like, hand to mouth, basically every week, just trying to function to begin with, trying to find a job that will accept you as you're going through transition. And in the United States, that's not a protected thing. In Michigan, it's just not. You can just be fired for being trans in Michigan, just period. You come out as trans, you're fired. That's legal. So imagine being in that situation already, and then this happens. So I'm actually quite worried about it. I'm very, very stressed about a lot of my patients, and a $1,200 stimulus check is not going to carry them for the next year and a half. It's just not. And we're going to be with this problem for quite a while.
What do you think, Dr.
Yeah. Yeah, I agree completely with Dr. Powers. And of course, we are also very worried about not only what is going to affect the patients, but the patients, they can imagine the fact that the crisis is affecting the whole chain of events that leads to surgery, from borders to airlines to the driver, the hospital, the hotels, everything. And we have been working, taking it for granted a bit, the whole circle of care that we deliver to the patient. And when a crisis like this comes, we have to really take a breath and observe everything around us, and we see that everyone is affected. So we need to be able to reinvent ourselves so that we can receive a patient and give the patient the same type of care. Imagine if, for example, the company that you have worked for years that provide you with the surgical mask or something more simple like some instruments that you use in the surgery, that company goes broke. So we had to really revise everything. So I'm worried about the financial situation of our patients around the world. As Dr. Power said, it's something that can happen specifically in the States, where you have a view of the problem, and then you can have completely different view in patients from Brazil or patients from Europe or patients from Asia. So yes, we are worried, and of course we want to help the maximum we can to support patients by changing surgical dates when necessary, adjusting to their needs. But yes, this is not an easy situation for everyone.
We have a question in the group actually that's related to the topic. And what are your opinions on getting support from the public health services in your respective countries, well, or your state? Because in the U.S. it's on a state-to-state basis, isn't it?
Yeah. Well, from here in Spain, let's say that part of the surgeries that are inside the transition process are covered. But as most of the countries that have the same coverage, let's say that on paper it's covered, but the amount of surgeries performed a year, it's very small. So they deliver the service, but in an amount that is not sufficient. It's far from sufficient. The fact that they still perform very small amount of procedures, of course, goes into a cycle of not highly specialized surgeons, because they don't do a high volume of these procedures. And sometimes the surgeons are changing all the time. So the public system needs to have not only the authorization to perform the procedure, but should do it in a volume that is acceptable to enhance experience. We have been working now, as you said, on the standards of care, number 8, and this is a document that is going to put, for example, the face with more importance than it has now. And this document is one of the helps we believe is going to reach the scientific community, but also the public systems and private health insurances to justify feminization surgery of the face as a needed procedure. And maybe it's going to be more accepted in other countries as well.
Absolutely. And so I think I'd like to know, to start off with, a little bit of background from both of you. Can you tell me a little bit about how and why you got to start working with the trans community? Dr. Powers?
Sure. Dr. Powers has a very nice.
It was a fortuitous accident. Often people ask me, they joke around, they're like, Dr. Powers, when are you going to come out as transgender? And I'm like, never. But they think I have like a family member or a friend or somebody that's this inspiration for me to do this. And I really didn't, actually. I ended up in family medicine because I originally wanted to either be a neurologist or a radiologist or a neurointerventionalist. But my wife and I wanted to stay together and not get separated in residency. So I took a family medicine position, and it was okay. But I wasn't super interested in a lot of the stuff I was doing. It wasn't as thrilling. So I kind of got into hormones and rare diagnoses and other stuff because I realized I could make a big difference and help a lot of people in family medicine if I could catch these things long before they needed to go all the way to a specialist. So I kind of got a reputation for that in residency, and I got a patient assigned to me because I was good at hormones who was told she had PCOS. I have PCOS, and she wanted to get pregnant. I said, okay, well, let's treat that. Let's work that up. And so I order some labs on her, and I go to do her PAP. And when I went to do her PAP, she had a clitoris that was about the size of like an everlasting gobstopper, like a spinning quarter. And that is not PCOS. That is most likely congenital adrenal hyperplasia, which I ordered a lab on and confirmed, and yep, that's what it was. So I asked her, patient X, do you find yourself attracted to women? Because the overwhelming majority of women that have this condition are attracted to women. And additionally, about 1 in 20 of them will transition to men. And she was like, no, absolutely not. No way, nothing, blah, blah. And that was it. So we kind of flamed on from the discussion. She got treatment. She got pregnant. Thankfully, it was a male fetus. Everything went fine. But while she was pregnant, she came back for her checkups. And she was like, Dr. Powers, I feel really bad about this. I lied to you. I'm actually more attracted to women than I am to men, but I've covered it up my whole life because I felt so embarrassed about it. And now that I know there's a medical reason why I feel this way, it makes me not feel so ashamed. But I just had to tell you. And I was like, oh, well, thank you for sharing with me. I appreciate that. She's like, well, that's not why I'm telling you, though. And I'm like, okay. She's like, I'm telling you because my sister says she's my brother now. And can you help him? And I was like, wait, what? And then I kind of put 2 and 2 together. Like, the condition can be autosomal dominant inheritance. And so it's 50-50 whether or not their sibling would have it. Their sibling did, and happened to be one of the 1 in 20 that would transition. And so I went to my attending, Dr. Sharon, who's a wonderful woman, and asked her, can I do this? Like, can I help this person transition? Because we were in a really rural area in Michigan and they had no care available down there. And she was like, no, you can't, because I don't know how to precept something I don't know how to do. But if you go get the training and you find someone willing to supervise you, then sure, you can. So I had one. The patient actually went with me to the training. We did it together. So like I'd learn how to do it. And I learned the WPATH method first. When I say WPATH method, I really more mean like the standards of care and then also the Endocrine Society's guidelines. And so I had 1, and then I had 2, and then I had 4, and then it was like Field of Dreams. Like if you build it, they will come. By the end of residency, I had over 50, and I ended up being nominated for Resident of the Year for it. But then I tried to find a job, and no one would hire me because I had in my application that basically these people are going to follow me anywhere. And I was chief and super chief at my program. I had top board scores. There was no reason that I shouldn't get interviews, and no one wanted to touch me. And a couple places were nice enough to say, we don't want those people here. So I couldn't find a job for a while. And then I eventually appealed to the LGBT organization in Michigan, Affirmations, said, I need help finding a job. I can't find anywhere to work because I'm trying to provide care to these people. And you want me to do that, so can you help me? And they ended up pairing me up with another office that I worked at until the fire happened. And then I was off for 1.5 years, and now I'm back, and 70% of my population is transgender, and I've got like probably 1,500 transgender people. It's crazy.
What percentage of patients are trans at Facialteam, Dr. Simon?
What percentage of what, sorry?
What percentage of our patients are transgender, non-conforming?
Well, at Facialteam, we are now more than 95% of our patients are transitioning, and we have started at some point to receive, without making any kind of let's say online effort or any kind of material showing the type of surgery we do for patients that are non-transgender. Without that, we had many cis women and cis men looking for finding our webpage and finding our material and identifying on their face structures that they would like to improve. For example, make the forehead softer, cis women with large jaws, cis men with very strong foreheads. So we started to get more and more patients that are cis and wanted to make a softening of the facial features, what we can call facial harmonization. But this is, let's say, it's a minority. Our day by day, we are operating an average of 30 patients every month. And from those, 28 are transgender.
What can you do for my Cro-Magnon man forehead?
A lot. We can do a lot, Dr. Powers. We can make a virtual surgery and show you what it would look like. And if you like it, you can come.
Get my Neanderthal nature under control.
Well, we can.
Like you said, Dr. Powers, the field of dreams, Facialteam.
Yes.
Similarly, it's just, it took time in the beginning, not like in your case, which I understand it was just like, woo, 6 months, the first 6 months, and just crazy. But yeah, talking about the demand, there was a question that a patient put to me before the live and said, is there a spike in the demand from the trans community, or is this a demand that just was never catered to? What are your thoughts on that?
The latter. Like the biggest problem facing the trans community, like overall, is access to care, period. Like that's like, if you ask me the question, like, what's the biggest access to care? It's not like these people haven't existed throughout history. It's like, you think this is some like movement? No, they finally got enough of a foothold in society that they're able to exist without significant persecution other than what they're currently getting. And so they're allowed to have a little bit more of a life presence. But if you look back, historically speaking, the Native Americans in the United States, many, many different tribes, and I don't want to lump them all into one, but many different tribes had the concept of two spirits. People who were basically of two souls joined together, and they were both male and female in one body. So like, this has existed throughout human history. It's just finally, we're like, oh, you guys are like redheads. That thing that we like wanted to burn at the stake because they were different. Oh, okay, cool. And like, that's it. Like we just acknowledged them as human beings like other human beings. And then now care to them is starting to open up and getting a little bit better. So that's what I would honestly say, that their biggest issue is access. And I would say it's improving, and it's good that it's improving, but it has a long way to go, because I shouldn't have 4 Australian patients that fly in from Australia to see me in Detroit. That's wrong. Like, that just shouldn't happen.
Yeah, we have the same feeling that, feminization surgery of the face has been around since the 80s, but it was like a very, very local activity in very small amount of places around the world. So not only it was very rare, but it was also very, very, it was not known. People didn't know it existed, right? So even nowadays, we have patients that contact us from some countries that when they contact us, they said it's the first time they knew that this type of surgery existed, okay? So it's the evolution that we had. We have been doing this since almost 2007, and the evolution we had of having more and more patients is not because there are more patients now. They have always been there, but they didn't know that first that the surgery existed, and of course, when they knew that it existed, they didn't find many of the times assurance that it was a procedure that was, let's say, scientifically based, that the results were predictable. And this is one of the reasons that first scientific publications in our field have been evolving a lot in the last 10 years, exponentially in the last 10 years. And it has given a lot of base for the patients to make decisions on doing and going for the surgery, which is not an adventure anymore. It's a surgery that is very well established. And it makes the patients also understand that this is a surgery that it's important to you. It's a surgery that you should include inside your transition process. So yes, it's for sure. It's something that if in the past was rare, now it's not rare anymore, and people were always there. It's not something new for them.
Absolutely. On this topic, I like to get your viewpoints about each other's fields, and I think that would be interesting for our viewers. And so, Dr. Powers, if you could tell us your thoughts, if you've had any patients that have had facial feminization surgery, and what your views are on the field of FFS. at the moment?
FFS is, if I could say one thing that I think is the most important thing to say, is medically necessary. There are a lot of insurances in the United States that state that, oh, that's not covered. It's not a covered, it's not medically necessary. It's not medically necessary. And we do top surgery for FTMs, and that's considered medically necessary. And I joke around about my Neanderthal face, but in all reality, I mean, if I were to try and transition my body, I would be stuck with this. I mean, can you see that? And my jawline, and this would be very difficult for me to pass. And so if the goal for transgender people is to allow their body to align with their internal gender identity, then the surgery should be medically justifiable. And I have seen a variety of results on people. I recently had a patient get FFS before they started HRT. And I was kind of I'm not a huge fan of this, but they were very insistent on it, and it's what they wanted to do and how they felt most comfortable. And ultimately, I let them proceed with that. Now, there are some concerns with that Dr. Simon and I have privately discussed, specifically about when HRT should be started and the effects that HRT will have on the underlying facial architecture because of the soft tissue. But in my opinion, I have literally seen nothing but positive interventions occur from both FFS and via vocal feminization surgery, VFS. Is the other surgery that's often just meh, whatever. But with a voice like this, I would not be able to vocal train myself into a more feminine sounding voice. I could try, but it just wouldn't be very good. And it's routinely denied. I think the only company in the United States that covers both unilaterally is Starbucks, which is why a lot of transgender people work at Starbucks. They have great health coverage. So it's kind of sad, really. But I think FFS is a wonderful tool in the bag of someone who's going through the transitioning process. It's really, really helpful.
Thank you. Dr. Simon, what are your thoughts on the effects of HRT according to your experience with trans women?
Well, as you know, our experience in feminization is completely connected with HRT. So we talk about HRT for many reasons. We talk about HRT because it needs to be working before the surgery for a certain period. We talk about the moment you have to stop or not HRT when you're having surgery. We talk about HRT after surgery. In general, as I explained to most patients, when we evaluate the face, we are making a diagnostic of the areas that have been touched by puberty, touched by the hormones, and that this normally has a cause that is leaving an effect on the bony structure. The bony structure can be addressed with surgery, but we cannot address some other aspects of the face that are mainly, we consider the secondary features, which is the soft tissues, the facial hair, fat distribution, size of the muscles, the quality of your hair. So the surgery that we do, we say sometimes even as a joke, but it's carpentry. I mean, we work cutting bone, we work shaping the structure of the face, but what people see is the outside. It's the whole. It's a combination of the structure with the soft tissues that go over it. So doing a very strong feminization surgery, being aggressive or not on the bone and not working on the secondary features, it's going to achieve a poor result, or let's say a suboptimal result. So hormone therapy for us plays a very important role. We normally encourage our patients to be doing hormone therapy for at least a year before their surgery. And what Dr. Power said, that some patients, they will do the surgery before hormone therapy. My personal opinion is that if you're doing hormone therapy before surgery, I think patients will enjoy more the results of the surgery sooner. I think that it's a very, very emotional period after the surgery in the first months, when you have swelling, you have the face that doesn't look very good in the beginning. If you put over it masculinity features from the secondary aspects or from the skin, you just add over the stress of the patient. So if one step can be already solved with the hormone therapy and secondary features are already nice and feminine, then when you do the surgery, what you see is already much, much nicer. And I think psychologically helps a lot.
That's a good answer. We've got a lot of questions, so many questions coming through.
I got all day.
On the topic of HRT, but
I could sit here all day.
We could talk about it a lot, yes. So we've answered, Dr. Simon just answered one of the questions that's come up. How long is it recommended to be on HRT before FFS, which is, it's recommended a year, at least 6 months now, minimum.
I would say even longer. I would say even longer. I've seen facial changes long after a year, especially in a patient who's not taken progesterone. Because I mean, I use my own face as an example of the effect of HRT, because I cheat. So one of the things I do, I'm 35 years old, I'm doing pretty good. And it's because I realized after many years of doing HRT, watching transgender women de-age in front of me. They literally just got younger as they started hormone therapy. And I'm like, how can I exploit this? So I use Estradiol, which is a much weaker estrogen, but has a lot more effect on facial collagen at 1% on my face twice a week. And it literally makes me look way younger. And that's just a subtle impact of a little thing that I do. The hormonal changes that occur that I see in patients take years. Anybody who tells you that transitioning takes 2 years is lying. When I went through puberty, I recall it taking considerably longer than 2 years. So like, you don't see a girl who's 9 years old and flat as a board go to, double Ds in the span of 2 years. Even if she did reach that level of growth, like that occurs over her entire teenage years. Some women's breasts don't even stop growing until they're in their mid-20s. So I would definitely take as long as someone was comfortable with before getting FFS.
I agree. I mean, we talk about at least a year. I mean, we know the hormone process is not going to stop after a year. It goes longer. But sometimes, as you said, it's a matter of organizing the patient's life. And it's true that after a year, it's very difficult that we can have any change of heart about one of the procedures we choose to do on the face. So since our analysis is mainly done by 3D scans, what we are mostly sure is that after a year, we are able to do comfortably the surgery that we would do now or in 3 years. And the patient will go on with the hormones, and it's only going to be an upward curve. So it's only going to be now results of the surgery and improvements caused by the hormone therapy for a more later treatment for 2 years or 3 years. But since patients, of course, they want to put things back, they want to go over some obstacles, they want to go over the facial surgery, we consider that a year is enough at least to make a good decision about the procedures.
Absolutely. There's a couple of questions related to the theme that we're talking about right now. And apparently there's a study, a published review on the degree of facial changes that HRT achieves with male to female patients. And they have two questions. One is, can you go through the facial changes of HRT alone? I think that's what they're asking. Would that be enough, just hormones to feminize the face? I think that's question one. And question two is...
Oh man, that's hard.
That is, does a better done HRT feminize the face better?
Yes, that one's easy to answer. Crappy HRT, it was one of the main reasons, I didn't say that out loud, but one of the main reasons I would say years is like, because some people come to me after being on hormones for like 5 years, and they've basically been on nothing. They're taking 4 milligrams of estrogen a day orally with 50 of Spiro, and they have like almost no progress, and they wonder why. Because they're like, their serum estradiol level is like 70 picograms. And so like, it's frustrating. But to answer the first question, I'm gonna let him go first because I need to look up a pharmacological thing about selective estrogen receptor modulators because I have an idea of how that could be done, but I'm not sure. So go to him first while I Google something.
Okay. Want me to repeat the question, Dr. Simon?
Well, I believe that, yes, I mean, hormone therapies, they have very different effects. It's difficult for us to talk about specific things that will happen on every phase. I think that even that, we don't have sometimes that perfect follow-up. I love when we get a patient that comes to us, and it happens a lot, on the beginning, on the transition, very beginning of the transition, and that patient follows through the surgery. This doesn't happen so much. So when we get a patient from the beginning to the end, we have pictures that we can really, really document the beginning and then what the hormones have caused. And then we are able to see if was fat distribution change, skin quality change, volume of lips, even size of facial muscles. But I believe that Dr. Powers has been seeing much more patients in this transition of the beginning to the end than us. We normally will get to the majority of patients already in an advanced stage of hormonization. So we see more of the already final or almost final result regarding the hormones.
Dr. Simon, it brings to mind a collage that you have of a patient.
I can show you.
Yeah, that would be good because it's really illustrative of a patient starting out before HRT, after HRT, which is before FFS, and then after FFS, and you can really see the changes. So yeah, but I agree with you. Every face is different. Every person's different. They're on different kinds of hormones, and so the effects are inevitably going to vary. Not everybody is going to have the same effect, but some people have quite good overall, not just the face, the body as well, humanizing effects with HRT. So Dr. Powers, have you found what you were looking for?
All right, so this is the standard Dr. Powers, where like I think of something outside of the box that I have very little scientific studies to justify, but my immediate thought was, if you wanted to feminize just the face, topical would be your best bet, because you can get obviously the most localized. So I create a topical testosterone. It's a very low concentration for transgender women. And I have them use it on the penis once a week, and then leading up to surgery, like every day, the few weeks before surgery. And the tissue that goes into surgery is not this sad, like wilted old lady penis. It's this big, strong, healthy penis, because it's restored from the testosterone. But at that concentration, when it spreads systemically, it's very low. So when I run my own estrogen levels, they're negligible. It's not like anything abnormal, despite the fact that I put this estriol on myself. And I calibrated it through tinkering with it a lot to get to that correct level. So that is one potential option, is topically. The other one that I was thinking was that you could utilize a selective estrogen receptor modulator, something like raloxifene or tamoxifen that we use for breast cancer, uterine cancer, whatever. But I'm not sure. So the way those work is that they're mostly anti-estrogenic. They block the receptors in certain tissues, and in other tissues, they allow them to progress. So there are SERMs and SARMs, like androgen receptor and selective estrogen receptor modulators. And so you can use these to effectively block some receptors while leaving other receptors exposed. So a person could, in theory, take estrogen while simultaneously taking a medication that would block only the receptors in the tissues that they wanted blocked, while allowing the other ones open. I don't think anyone's ever done that before, and I've never been asked that question, so I don't have a lot better of an answer than that. So I don't know exactly what the most logical combination of drugs would be, but that pharmacologically would be how I could imagine accomplishing that.
Thank you. It's very honest of you to say, I don't know, and I think a lot of people don't dare.
Yeah, do you want me to try to share the screen and show a picture?
Yeah, please do. Share that. Share that
Perfect.
collage that you have that shows the patient from.
Good. I have two collages here that I can show.
Before HRT.
Yes, exactly. So this is a patient before HRT and pre-FFS. This was one year HRT. So I think that you see, Dr. Powers?
Yeah, the buccal fat pad is considerably, like, that's really the biggest thing I noticed. And then the area over the zygomaticus is also considerably improved.
Exactly. Also, we noticed a decrease on the thickness of the masseter muscle on both sides, which was very interesting as well. And what is more difficult to see, but the quality of the skin is much better. Do you see this, Dr. Powers, this improvement so strong on the quality of the skin?
Clearly. Is the orbicularis oris weaker? Is that what I'm perceiving around the mouth?
Yes, it's possible. And here I have another picture, a patient a little bit older. Let me see, it's a little bit small, right? Let me go a little bit like this. So again, it's a patient pre and post hormone therapy without surgery. The surgery was still not, even you can see hair recovery, different on quality of skin, facial hair removal. So hormone therapy, this picture for me, I show it in a lot of events. It's so powerful, right, Dr. Powers? I mean, it really shows how it's not something to take it for granted that hormone therapy is extremely important.
You can literally look at the like the aging of the face. They look younger, and I mean, they literally look like it's why I exploit this for myself. I mean, it works.
Exactly. So yes, a patient was asking if you can. I don't know if they asked if you can do only hormone therapy without facial feminization. Of course, you can, but if you have prominent structural bony structures caused during puberty, this will not disappear, and then you have to evaluate your final result with the hormone therapy only. If you are happy with it, perfect. If you want to, if you're not so happy, then you have to address the areas that you're not happy with. There's no. Let me just go back to here. I want to say here. Okay. There's no rule in facial feminization nowadays. I mean, the rule is that it's called common ground. It's when we can make technical, of course, identification of features that have been affected by puberty. But on the other side, we have a patient that has her own perception about her face. As there's no rule about having tiny jaws in feminization surgery. You know how many millions of cis women have strong jawlines, and this is not something that we should eliminate to everyone. So we have patients that they have a little bit of a strong forehead and they don't want to remove it, but they're very concerned about the Adam's apple or the nose. So this is the common ground. Is the patient the one that has to live happily, comfortable with her face? It's not us as surgeons that should go for the best possible results to show in the gallery, you understand? So I think that's it. Hormone therapy can be enough for many patients. It can. For other patients, you may need hormone therapy and some amount of procedure. And for some patients, you need a lot of procedure.
Dr. Simon, are you proposing that the care of transgender people should be individualized to each individual patient with both their hormones and surgical options instead of just thunk the cookie cutter down and making another one? Is that what you are actually proposing?
Yeah, as crazy as it sounds.
Position.
I know, and I believe it happens in your area and in our area a lot, right? I mean, what is the formula? What is I want a formula. I want the pack. Doctor, I want to do an FFS, and they think that's it. It's an FFS. It's not yeah. So I think it's a problem of information. And I love when we do video calls that we do every week with many patients that when they leave the consultation, at least understanding that there are so many procedures where we can choose from and establish the best plan is already a big good start.
Absolutely. I have a lot of questions are coming through about more specifics on HRT, Dr. Powers. So someone's asked about progesterone. Someone's asked about your thoughts on pellets.
Sure. I can give the brief overview of how I do things differently. When I first started doing HRT, I followed the guidelines. USCF and when they say WPATH guidelines, really we more mean WPATH's endorsement of the Endocrine Society's recommendations. And to be honest, it's very frustrating for me because I have become like the spike on the end of the halberd that these people are using to attack these organizations. And they think that I endorse this, and I don't. I actually love WPATH. I really want to work with them. I think they're great. I think they do wonderful things. I disagree with the fact that the Endocrine Society recommends such high doses of CPA in Europe. I mean, there's a lot of things that I think could be done a little better. In my patients, I don't really need blockers, which is kind of unheard of in trans medicine. Everybody goes on a blocker. And I use estrogen and progesterone themselves as an anti-gonadotrophin, almost like Lupron, because both of them they bind up in the pituitary and they inhibit that feedback loop with gonadotrophin releasing hormone, and then LH and FSH drop to zero. And so what I effectively do is I do a chemical orchiectomy. I give them Lupron, but through estrogen and progesterone. So my patients don't need Spiro. I give them bicalutamide very early in development before I get what I call capture, which is where I control their LH and FSH by using the drugs. But that, for me, hormones are considerably different than the way that it was typically recommended. I do what is unique to each of my individual patients. I run labs on them. I monitor their estrogen metabolites. Some people metabolize oral estradiol kind of weird, and they make a lot of estrone. And I have a theory that results in increased thrombotic events, as well as being like a competitive agonist where it's fighting the receptor for the same spot. But I guess overall, my hormone therapy, I mean, I have a publication on it that's unofficial. I have a PowerPoint and I have a YouTube video, and I really would like to publish it. I was about to publish my estrone theory in 2017, and then my house burned down and I almost got killed. And I was in pretty bad shape physically and mentally, but everything in my home got destroyed, and my old boss wouldn't give me my old medical records. I had to literally fight them to try and get medical records of my patients so that I can publish some stuff. Then I used to be affiliated with a hospital system, so I could use the hospital's IRB. Now in the United States, we require an IRB, which is this like organization that is part of a larger academic or whatever that says if you're experimenting on humans, you need to get approval to do these things. Even if it's something super simple, like literally anything involving more than 3 humans requires IRB approval. Well, now I'm private, so I'm not affiliated with Ascension anymore, so I don't have an internal IRB. So I'm trying to find an external third-party IRB that will approve the research that I want to do, and simultaneously getting enough data to publish some case reports so that people start taking me seriously. Because when you look, and you said it earlier, like I have a bazillion reviews on everything and they're all 5 stars. There's a reason we're having this conversation, and you guys are this illustrious, super famous organization in Europe known for being some of the best FFS surgeons in the world. And I'm a family doctor from Michigan. Like, let's be real here, okay? There's a reason, though, that I'm able to talk to you, is that the word of mouth about my techniques working way better than everybody else's has gotten around. But I have published nothing. And I really want to. And to do that, I need to be friends with some of these other organizations that I may have a professional disagreement with about 1 or 2 things, but about 97% of what like WPATH puts out, especially in their own journal, I'm like, oh, awesome, this is great. What they do, the amount of effort and time and love that they pour into this community, it drives me crazy to see these patients using me as like the pencil, like, attacking WPATH, when really what they're mad at is not WPATH. WPATH is the word that's said to them by their doctor, who says, well, we follow the WPATH method here. There isn't even a WPATH method. That's not a thing. They have their standards of care, and then there's the Endocrine Society guidelines, but doctors collectively say that probably because it has the word path in it. So it's like, we follow the W path. We go along this path. And so that gets justified to them as the reason why they're given almost no estrogen, and they're not given progesterone. They're, oh, there's no recommendation to do that in this guideline, and then that's it. And so the patients are frustrated and angry because they see other people getting better results. And so who do they attack? They attack the justification the doctor gave, which wasn't even true in the first place. So like, I know that this is probably kind of off topic, but I want it very clear that I really like UCSF and WPATH a lot. I want to hang out with them. I'd like to take them out and have a beer. Like, but my patients and other people on the internet are using me as the weaponry to tear down the very people who are trying to help them. So it's a very complex situation with HRT right now in trans medicine. And yeah, I think my way of doing things works better. In 7 years, I have had 0 thrombotic events. I attribute that to using only bioidenticals. I use no synthetic anything ever, and to monitoring estrogen levels. Knock on wood, but I've had 0. Statistically, I should have had 5. I have a really good outcomes. I think that's because of the way that I adjust, the biochemistry of these patients. I use all kinds of crazy stuff. I use boron to inhibit their sex hormone binding globulin, because once their testosterone level drops, sex hormone binding globulin gets bored, and it likes estrogen about half as much as it likes testosterone. So it frees it up by inhibiting the boron binds the sex hormone binding globulin, which allows more free estradiol, which gets you more effect out of the same estradiol level. There's all kinds of tricks you can do in HRT.
So a question on that specific topic, a couple of questions actually. One of the questions that was asked before was actually, what degree of changes can we expect on a face with HRT alone? Can you put millimeters to the differences? Because this patient is saying they don't see the differences before and after in their photos, and they're trying to gauge realistically what to expect from HRT. They're
probably underweight. I would wager money they're underweight, because generally what you see is this jowl here, this goes to here. I don't know how to like accurately really show that, but like this travels up here and they get like a little pooch of fat here. That is the primary thing that I see as a shifting from the jowl line up into this zygomaticus area underneath the eye. And that happens after about a year or 2, and progesterone helps with it.
A year or 2. It's interesting you say that, because I didn't tell you the rest of the message, and they actually continued to say, I have a very masculine face with sunken cheeks and strong cheekbones and jawline.
They're thin.
So it's
if you don't have enough fat, like I always tell my patients, I can't feminize Skeletor. So like I have patients that come to me with a BMI of 17, and they're like, I'm not getting any breast development. And I'm like, are you surprised? Like, I need some Play-Doh to move around, because breasts are mostly fat, like they are. I mean, you can get the ductal dilatation, you can get the mass, like, when I say mast cell, like breast cells growing. I'm commonly referring to nipple plate fusion with spironolactone, which I regret ever saying. But the breast bud, which I refer colloquially to the nipple plate or the breast bud, almost like a growth plate. It's not a growth plate. It's similar to a growth plate in that it's the tissue matrix that is expanding and dividing. But I have some theories about what can limit that. But this patient comes into me and is like, I'm not getting much breast development on your method. And I'm like, you need to eat. Because breasts are primarily fat. So I would wager money that this patient's relatively thin and doesn't have a lot of facial fat. So they're not seeing the change. I'm also messing around right now with weight cycling. I'm curious if hormones act as like a gating mechanism, where, like, if I had a beer belly and, I get on hormones, it doesn't just magically go to the breasts. But if I were to lose said beer belly while on hormones, would that open the gates, so to speak, in feminine distributions and close them to addition in male distributions? And I don't know the answer to that yet. I have a few patients that are athletes that are willing to try it for me right now, but it'll be a good 6 months to a year until I have 4 or 5 people I could even report on. But anecdotally, I've heard good things with weight cycling, and that may be the reason.
Another question related to HRT. Sorry, Dr. Simon.
I have questions for him.
It's okay. I'm enjoying a lot. And I haven't here my own questions.
I'm in no rush. I can stay here all day.
Yeah, we're not in a rush. I just want to make sure that the people, our viewers, are getting their questions answered too.
Today I think Dr. Powers is our honor invited, and we have to squeeze him from all the information we can, and I'll make my question as well. And anything I can comment, yes, I will comment, of course.
Bring it out.
Yeah, actually, I should say at this point that thanks to a couple of mutual patients or contacts, that we're really excited to hear that we were doing this, and they helped me a lot. And one of in particular has been the person who got us together. So thank you very much to the community of patients who are also raising their voices, and that's really important for you to raise your voices and get the professionals talking to each other, and that's what we're doing today. So the question for you, Dr. Powers, is it true that the lack of both progesterone and testosterone can cause degradation of the nervous system and cause brain issues?
So I don't know about degradation of the nervous system. That's kind of aggressive. But I used to date a girl in college who is a neuroscientist. She's a PhD in neuroscience, and she did research on mice. Specifically training said mice by giving them either hormone blockers or hormones on a mouse maze. And then they would basically sack the mice after they finished the thing, and then they would look at slices of their brain. And they noted hippocampal atrophy in some of these mice that were on hormone deprivation. And so the mice that they gave estrogen and testosterone to performed better. And so in both male and female brains, there are receptors for neurocorticoids, but also sex hormones. So that is a known phenomenon, and I have absolutely seen patients that, this is why I say that my estrone, good example, here you go. Patient comes to me, has an estradiol level of 300 and an estrone of 4,000. They're on oral. And they are basically taking all the oral that I'm giving them and shunting it into estrone in their liver. A lot of people say that doesn't matter, it's irrelevant, there's no clinical indication to estrone, but I'll take that same patient and I'll switch them onto injections. I will set their injections such that their estradiol level is 300, and now their estrone is 250 because they're avoiding first pass metabolism. And they tell me it feels like the film has been peeled off their eyes. That like they have infinitely more energy, they're more cognitively aware, they're less tired, they feel smarter, that it had a huge impact on them cognitively. So I don't know that progesterone, testosterone, estrogen, lack of them will cause degradation of the nervous system, like that you'll get some sort of like severe decay syndrome. Progesterone, interestingly, is a precursor molecule for the synthesis of something called allopregnenolone. That drug slash hormone is a neurocorticoid that is actually used to treat postpartum depression now. The drug's called brexanolone. And we infuse this synthetic allopregnenolone into these women that have severe postpartum depression, and it's like an overnight cure. It's also like 30 grand. It's incredibly expensive and has to be done in a hospital. But I've had patients that have post-finasteride syndrome, which is this kind of poorly understood thing that happens to some people after taking 5-alpha reductase inhibitors. And I've treated them with simultaneous oral and rectal progesterone because you get mixed metabolites. When you take it orally, you get more like neuroactive metabolites. When you take it rectally, you get less metabolites really of all. It stays more as bioidentical progesterone because it has to then evade the first pass of the liver. So I guess to answer that, overall, yes, there are definitely things that deprivation of those 3 hormones would do to a person's brain and nervous system, but I don't know if it's as severe as would be suggested there.
Thank you. That was a very thorough explanation. Talking again, Dr. Simon, we mentioned that the recommendation is at least a year of HRT before FFS, bare minimum 6 months, but it's more is better. And Dr. Powers is saying, you know, even up to 2 years before to really get the full benefit of HRT.
Let me ask him this, because I actually want to know the answer to this just for the sake of professional collaboration, if you don't mind.
Sure.
I see these facial changes that occur even up to like 2 years. And on my hormone therapy, I'd say 2 years, but other people might take longer if they weren't as good a therapy. Do the soft tissue changes I see at 1 year, 2 year make such a difference in terms of the surgical outcome that you would want them to be completed? Like basically the underlying architecture of my face is the bone structure, but would this buccal fat pad moving up here make such a difference as that you would want to wait? Or can you kind of predict that and it's not a thing you have to worry about?
Well, I would say to you that mainly, since one of the main changes we see from the hormone therapy is around the zygomatic area, the cheek area, I would not say that we would wait to perform surgery for many years for a final result. But what happens most of the times is that we can predict that 2 things will happen. First, that we have an objective increase or enhancement of this area after some time. So maybe we should not operate on that area, okay? The cheek area is an area that we normally leave for a second stage for 2 reasons. First is this one, and the second is that most patients, when they will have a surgery, a general FFS that addresses a nose that is large, a forehead that is prominent, a jaw that is wild, only by doing it and reducing those other areas, the cheeks appear much more naturally, even without an enhancement. So the cheeks is one of the areas that we have been changing our way of addressing more in the last 10 years. We had even placed cheek implants some years ago. We are not placing cheek implants anymore because we trust more in the hormone therapy and we trust more in the balancing of the face after the reduction of the neighbor areas, okay? So in patients that we identify, they have been doing hormone therapy for more than a year, even more than this in general, from patients that are doing long time of hormone therapy, and they definitely show a deficient cheek area that is clearly sunken, we will work with fat transfers. Fat transfers, they show us the better possible results, more natural. They are not a risky procedure for the future. If you compare with cheek implants, where you can have rejection, displacement, necrosis, exposure, or even sclerotization when you start to see the contours of the implant after many years. So the fat transfer is a much more natural way of doing it. So yes, we normally predict that this area is one of the more sacred areas that we should not address in the beginning.
What do you both think about suspending hormones before surgery? Is it necessary?
Yeah, this is a good question. Yeah, we get from most patients that there is a general knowledge that hormones should be stopped before doing any kind of surgery. We have worked for many years with a very strong team of intensive care and anesthesia and established a protocol where we do not stop hormone therapy before surgery for some reasons. But one of the reasons is that we don't want to interrupt the hormone therapy. We know that going back to the right levels is not something simple for the patients, and we want to keep the patient psychologically on their best fit, best situation, best shape during the surgery. It is a traumatic experience. It's a very important and emotional moment. Our patients, they are going to be mobilizing, so they walk even on the day of surgery. After they wake up, they can go to the bathroom walking. We will use an antithrombotic agent before surgery And we have had, again, touch wood, we have never had any kind of thrombotic accident in these years. I have been talking to Dr. Powers, and I know that he agrees with that approach, right, Dr. Powers?
Yes, I do, with the exception of oral. So a lot of the prothrombotic aspects, the profibrinogen and the thrombin generation that comes from estradiol comes from when it's consumed orally and it passes through the liver. And so subsequently, someone who's on oral estradiol, I would stop. But that being said, I've had 7 surgeries related to a hernia that I developed when I was in medical school. 7. I was very unlucky. I got the bad mesh. It got rejected. I had nerve surgeries, cut this nerve, radio ablate that. It was a nightmare. Many, many years of chronic pain. And before I went under for each of these surgeries, they of course unplugged my testicles. And then after the surgery was complete, they plugged them back in because that's what we would do, right? No, my hormones remained normal during that whole time as they normally would. My wife, when she was 28 years old, and I still can't imagine how this even happened because she's wonderful about, she looks, you think I look young, my wife looks incredibly young. She wears sunscreen every single day of her life. And she got melanoma and had to have a wide excision of the melanoma. And basically, same concept. They didn't take her ovaries out while she underwent this surgery to have the melanoma removed. So in my opinion, bioidentical hormones given parenterally at physiologic levels should not be stopped because we do know that elderly people who have low hormone levels heal slower. We can see negative impacts of healing and wound recovery and other aspects of a lack of hormones on people. So I don't think that we should have someone at an estradiol level of 1100 during surgery, no. But at a normal cis female physiologic level of estradiol given parenterally to avoid first pass, yeah. Trans men, I think they should have some testosterone. Starving them of the hormones, I think, does more harm than good. And I believe it's more of an arcane practice related to fear. And because it's like one of those things that gets carried forward, no one's going to challenge it. No one's going to be like, you know what we're going to do? Not the standard of practice of stopping hormones. Then we'll see what happens and whether or not we should have done it. And so it just continues as chart lore forever.
So you say no.
That I would like to one thing that I would like to ask you even is that I think that it's a good opportunity for us, not during the live now, but that we will send you our current protocols. The ones we have now have already around 2 years, and I would really love you to check our current protocols about pre-op, during stay in Spain, and after surgery about the hormone therapy regime. And if you could revise this for us, would be very nice, because we try to work with collaborations like this where you have experts from their field and they can give this input to us and improve the quality of what we can offer. So if you are willing, we are going to send you some material to check for us and give you our feedback, please.
I am more than willing to do that, though I want to stress the fact that I am looked at as a world expert in HRT. That's a thing. It's just on the internet. And it's quite unfortunate because there are people who are DIYing my methods that will mess everything all up and be like, oh, use the boron rectally. And what? And I have published nothing. I really want to. So people who are watching this, please stop using me as the weaponry to attack these organizations. I really would like to get published. But that being said, I'm happy to look at it and give my thoughts and opinions on it, but understand that it's kind of the same way that I view everything. I have the unfortunate gift and curse of being autistic. Everything to me is black and white. So it's the very reason why I looked at HRT the way I did, is that authority to me doesn't really click as a thing. Like you're an authority in your field, but it's not just because you have this name, it's because of what you've accomplished. Your deeds matter more to me, so to speak, than your title. And so that's the way I feel about HRT as well. And so I'm happy to take a look at that for you and evaluate what I think, yeah, this seems reasonable, this is good, but know that it's just one family doctor in Detroit's opinion who gets way more credit than he should get.
I don't think so. I really think that first, of course, a collaboration like this always is amazing for us. And I think that your work is the same thing as our work. It talks by itself. I mean, the feedback we have from your work
it's so strong that got you, that we were so interested in talking to you and bringing your opinions to our patients, to our patient group. So one more time, I really appreciate you being here, and don't underestimate your capacities, because I really believe you're really top level guy.
Thank you. I know it works. The patients know it works. You can just kind of look anywhere on the internet, and there's a reason that it's like the random family doctors method became so popular. But that being said, I really have to prove it. I have to be able to prove it. So I need to get with
when we started, we haven't published anything in the beginning, and then we got to a point. It took almost 4 years for us to make our first publication. From that point on, we didn't stop, and I would love to propose to you that you check not only our protocols, but if you are interested in working together with us in an article talking specifically about hormone therapy in feminization surgery, you are already invited here publicly.
That would be wonderful.
To have you on board.
I would love to do that.
Then you'd get published. And like
I'd be a real doctor all of a sudden. I'd be
like Dr. Simon said, I happen to know two guys that were also, young 30-somethings like yourself, Dr. Powers, at one point, and didn't have any experience, and were not published, and it took a lot of hard work and time and effort. And it's just a matter of time. You've got the experience, you've got the community behind you that believe in you and trust in you, and your methods are working. So keep the faith.
I wouldn't be where I am right now if it were not for this community. You have to understand that, like, after the fire, I was not good. I was in pretty bad shape. And I was like literally sitting out behind the back of my burned ruins of my home, sobbing, like laying on the ground, all disoriented because I was in that bad a mental state. And my own patients came up to me and found me because they were out in the woods behind my house searching for my cats for me. I would run into them in the woods, just wander like around my home, a couple miles of woods around my home. I would run into them. These people like lifted me up from the ground. I mean, I guess I kind of know what it feels like to be trans in some ways, in that like I lost my family, I lost my home, I lost my job, I lost all of my things. I felt ostracized and I had grief, and it was awful. Like I got if there was any purpose to the fire, if there was a God that was like, I'm going to do this to you, so you understand suffering. Maybe that, but these people are the reason I'm still alive. They propped me up when I was at my absolute worst, and as a result, I will fight for them for the rest of my life. I can never repay them back for what they did.
That's an amazing story. Can you show us your cats?
Yeah.
Yes, please. Sure. But not only show, I really love you to explain us what is the work you do with your cats, because I think it's amazing. I mean,
so I have 6 cats, and the ones that come to the office are the exotic hybrids. And so they don't have the FELD1 gene. So a lot of people think that it's the cat dander that actually makes the allergy happen. It's not. It's their saliva. They lick it onto themselves, and then it's the dander. So the hybrids don't seem to have it. Some do, but mine just don't. And so they can go to the office. So I have a patient that has anaphylaxis to cats. She carries an EpiPen in case a cat rubs against her as she walks down the street. And she could pet my cat. And she literally sobbed because it had been 20. She loves cats, but couldn't touch them for 20 years. So I have... it is a gaming chair. I see that comment right now. It's kind of funny. I'm a huge gamer. If you can't see behind me, I've got like a Final Fantasy VI Atma weapon scene. I mean, I'm a nerd. I don't lie about this. I'm a huge weeb, otaku. But anyways, let's grab the different cats. So this is Phoenix. Phoenix is the half-brother of Arcturus Aldebaran Powers, who had the world record. He's pretty big, as you can see. He's a Savannah cat, but he's full grown. So like he's a big boy.
Wow.
Wow.
Then we've got Polaris here. Come here, Polaris.
They're all named after stars, or
they're all named after stars or astral objects. Yeah. So this Polaris, he's a marble Bengal. He goes to the office as well. He's a therapy cat, and you can see they're all really docile. Like I can. Like they don't,
okay.
They've been raised since the time they were little to be very chill.
And you train them yourself to be emotional support cats.
This is Hyperion. He's a rosetted Bengal boy. He's my most docile cat. I mean, I can literally do anything to him. Hi. I mean, I can literally like chomp him. He loves daddy. And then we've got Corvus. Corvus is the full brother of Arcturus. He's going to be pretty big. He's only 8 months old, so he's growing.
Wow.
He's a big cat, but he's not too huge. Then we've got Altair over here. He's the Maine Coon. He doesn't get to go to the office. Hi, Altair. Did I pick you up? He can't go to the office. His brother had the longest tail ever on a cat. You can see he's got a pretty good one himself. Oh, yeah. But he doesn't go to the office because he's a big fluke and he would trigger allergies. And then lastly, I have the monster. This is Fenrir Antares powers. And Fenrir, he's an 8-month-old kitten that weighs 21 pounds. I don't know how to describe to you how large this animal is. He's going to be just freakishly huge. So, like, I'm going to back up so I'm kind of get
There goes Final Fantasy.
That's how big he is at 8 months old. So,
wow.
like, he's heavy. But when you raise them right, people don't get cats. They're like, oh, cats are mean. Cats, I like dogs. If you raise a cat right, they're just like, they're docile and chill and they love you. Phoenix, come here. Will you give Daddy a headbutt? Can you have a headbutt? Hi. Do you see him on the camera?
Yep.
Yeah.
Kiss. Good boy. This one. That's my good boy.
Oh.
Will you give Daddy a kiss? Oh, good boy. You can train them to do anything. But they're good animals, and if you raise them right from the time that they're little, they can be very exceptionally friendly and loving animals. I love cats. I'm a cat guy, not a dog guy.
Amazing. Well, then I don't show you my dog.
I think it's a very, very good idea to have, apart from the cats, you know, the gaming and everything, that helps people who otherwise would feel very nervous going into to see the doctor, as many people typically are, and it helps them to come out of their shell a little bit, doesn't it?
Yep, that's why I did that. I mean, so when I had the idea for my clinic, I thought about my population and who was going to come. And these are people who they hate seeing the doctor. It's a battle every time, right? They're nervous, they're threatened, they feel uncomfortable.
Especially if they've had bad experiences.
Oh yeah, they all have. And they're often hostile to me when I first meet them. They're very distrustful because that's what they're used to. And so it's like PTSD from that. So I came up with the idea for my clinic and I told my colleagues about it and they told me how stupid I was. They were literally like, that will never succeed. It's unprofessional. People won't want to do that. I'm like, all right, well, we'll see what happens. So you walk into my office and there's like anime playing on a big screen TV. There's an arcade machine. And then there's therapy cats walking around. You walk up and you get like weighed in a scale that has like a skeletal Mario with like anatomy on it in front of it. There's x-rays of video game controllers going around. The nurse's station has nanoleaf LED panels cycling an internal rainbow that just loops around. Every room has a Roku TV with like Netflix, Hulu, Crunchyroll, all kinds of stuff. And then a SNES Classic. So they can literally play like Nintendo and Super Nintendo games while they wait for me to come in. All this was really fun pre-pandemic. Now that, no one's playing the games now. But it was really cool before all this COVID stuff happened.
Yeah, well, hopefully things will go back to normal at some point in time in the future.
Okay. At some point in the future, it will feel normal. But I would say that the world is very permanently changed from the situation. And it's going to last a lot longer than people want to admit that it is.
Dr. Powers, we have been noticing in the last couple of years a big change on the average of our patients' age. When we started, our patients, they were on average
over 40, even 45. And last year, we have operated more than 300 patients, and the average was around 25, 26. And we are getting more and more patients that are even younger, 18, 19, much more family support we are seeing. Is this something you're experiencing as well? Do you have patients from all ages doing HRT, or is more of a tendency of going to one certain age?
I mean, my youngest patients doing HRT are those that just cleared psychiatry, so they're typically around 13, 14. I'll block a kid. So like I had parents bring me a kid who was like 8 and their kid was assigned male at birth, identifies as female, and they brought him to see me all the way from Wisconsin. And I thought I was gonna like give them hormones. And I was like, no, like, well, what about blockers? I'm like, they're 8, like send them to gender therapy. There's nothing else to do. But my oldest patient is, well, I started them at 81 and they're now 84.
Wow.
And they told me when they basically came in, they're like, I didn't get to live my life as my authentic self, but I'm definitely going to at least die as my authentic self. And I was like, all right, cool. So I was worried about them having complications. So I did, carotid duplex, echo. I mean, I put them through the ringer hypercoagulability testing, passed it all flying colors. They were in good shape. Started them on HRT. They're very happy. But I actually recently, I was curious what my average patient age was. But the other day I was looking at my Google Analytics, and about 80% of the people that walk in the door are between 25 and 35. So I'm going to guess my average patient age is somewhere around 28 to 30.
Yeah, very close to us. Yeah.
It's very similar, yeah. Yeah, we're getting people coming in with their parents now sometimes, so.
Many times, it's amazing.
To go back a little bit to the HRT topic, the last thing we were talking about was in HRT around surgeries, and you said if they're taking oral, and then they should suspend, but you didn't mention, I don't know, maybe I missed it. Did you talk about maybe switching instead of having to stop switching?
I've done that before. So here's what I always do. I say, does your surgeon have an opinion? So like McGinn has an opinion. She stops. And I respect that, because I'm not going to meddle in someone else's kitchen, right? That's their domain. She runs her OR and controls her patients post-op. So she says, deliver them to me like this. Okay. But occasionally I'll have surgeons say, do whatever it is that you think is best. And in that case, I will usually put them on a patch. And the reason I use a patch is that it's easy. We don't have to worry about them getting an injection in the hospital. It's just like slap a patch on. Someone can do it for them, even if they're all like doped up on the morphine drip. And that way they have some degree of functional sex hormones. I usually use either, depending on their body mass, 0.1 or 2.1s, like the max dose patch. And I try and target their estradiol level to be like 150. Just enough that they have a physiologic level so that they're not miserable. For my trans men, I keep their T around 350 for that, like during that time frame. I'll cut their dose down a little, but I don't want them to crash out into a subnormal physiologic range. Because if I was going to get surgery, they would not remove my testicles. So there is not a lot of difference in regards to a parenterally administered hormone to that which is naturally produced. So like, I don't see the logical justification in that. To me, it seems like it would only harm the patient. But despite that, I will do what McGinn says, because she's the boss. I'm just the family doctor, but like if it's deferred to me, then that's what I choose.
Absolutely. It's good advice. Some of the questions from our viewers, comments, is that in Europe, injections aren't really widely available. It's very difficult to find injections. And so some people were asking, what's your advice if injections aren't available? And someone also asked about estradiol 0.1 gel, if instead of using injections. What do you think about that?
It works crappy. Transdermal estrogen right now is a thing that commercially is terrible. DIYers are literally hacking the biochemistry of this and combining it with stuff and producing it illicitly on the internet, and the effects of that have been incredible. I make a Estradiol Topical that I have for patients that, would you like to go out, Phoenix? He knows how to open the door, so I'm just gonna help him. Here you go, you can go. I make an estradiol that's compounded with DMSO. And so they have other forms of penetrance other than that, like trimethyl, something, but there's a bunch of different drugs you can combine with the estradiol. Oh, hello. There's another big boy going by. To increase the penetration and get better absorption. So plain old estrase cream is not going to get the job done. But if you can combine it with something else, you may be able to get better performance out of it. But I'm never going to say, because like I said already, the DIY community takes what I say and just runs with it, and it's dangerous. Oh yeah, buy some DMSO from Amazon, smear that on first, and then put on the estradiol. Well, yes, that would work. You'd get more effect out of it, but how much? And that's where you need a doctor and labs and something to refine that for you. But in Europe, I would say if I were in Europe and I were a transgender woman, I would work with getting a compounding pharmacy to make me a topical estrogen combined with some penetrant. Because effectively, if you could achieve estradiol-like levels, then from an injection estradiol-like levels, then it'd be the same thing.
There you go, a new business line, Dr. Simon.
There are a few compounding pharmacies in Europe that do make injectable estrogen. There's one. I know there's one in Germany. There are a couple. Okay. So but it's not a commercially produced product for some reason, and I don't know why, because it's commonly used for fertility treatment. So I don't know what you guys use over there.
Yeah, I don't know. I couldn't tell you either. I'm not an expert in in hormones or hormone therapy. But one of the things we talked about the other day, Dr. Powers, when we had our planning meeting with Dr. Simon, is how could you work with us in terms of helping to optimize our patients' results? So what was
part of the private discussion I had with him was about what I can best do. So with the genital surgeons, I do the topical testosterone, right? Or if they're going to have a metoidoplasty or whatever, I'll take them. I'll put topical on the clitoris area, like 15%, get better growth. Then right before the surgery, have them use a bunch of estradiol cream to like restore the health of the tissue. So like we were discussing what would be the best options for topicals or other treatments that I could have compounded for my patients to send the facial skin in with like the highest collagen levels, like the healthiest possible skin I could produce. And so that is absolutely something that I would love to work with you guys on.
Yeah, this is amazing. I mean, we know that the hormone therapy, it's a systemic treatment, and topical treatments, they have to be still more evolved, you know, and I'm sure that they can work very well. And if they can achieve an extra level of softness on the quality of the skin, an extra level of that, you know that I have a trans friend that tells me always this, that there's something that happens on the skin after many years of hormones that is such a glow. It's something that is difficult to measure. It's difficult to describe. And it's a glow. The skin becomes more healthy, becomes more, right?
It's this. This is Estradiol. It's what that does. I mean, it's why I look this way, and it makes me younger. It's cheating. It was just a neat trick. And you know, I tinkered with it enough with topicals to like, you know, so I made sure I didn't get breast development because I am very cis. I like to be good looking and young, but manly. And so you're 100% right. It's that effect that just, it takes a while, but then they have that like pregnancy-like glow. They look younger and healthier. And sending them to you with that, I think, is probably best for their healing as well. There's improved wound healing during pregnancy and other stuff as well. So like we know that. So like it would stand to reason that.
Right. On the topic of that glow that you're talking about, there was a question in the group from Christina for Dr. Simon. The tissue trauma after surgery stimulates collagen production. Is that true? And she's also saying, I'm just wondering if everything will tighten up a little, even though you are removing hard structure under the tissue.
Yeah, I know. I mean, it's a common question. I don't know if normally patients, they don't ask us in this way about collagen production, but more about tightening of the skin, of the soft tissues after surgery. So as you know, when we are doing the facial surgery, there are some key areas where not tightening, but adaptation plays a very important role. When we are doing a forehead surgery, the skin and the soft tissues of the forehead, they are thinner. There is less, the skin is thinner, the amount of muscle is smaller, there's a small amount of fat layer. You can really touch your bone really, really easily here, but it's not the same as when you touch your jaw, for example. So normally the adaptation or the tightening of the soft tissues of the forehead after the bone reconstruction, it's very good and quick. It's not the same as in the jaw and chin area. So in patients that are younger, you will see a much quicker and effective adaptation of the soft tissues to the new bone shape. Normally is a reduction. So if you make that jaw smaller, the soft tissues, which is again, skin, muscle, fat, all of that is going to go towards the bone and you're going to have a good adaptation. But it's true that in some patients over 45, over 50, if you go for a reduction that is too aggressive, you may have some sagging or some lack of adaptation. In those cases, you will need to go, if you want a better jawline, you may need to have a facelift. When we are doing also the surgeries of the jaw and the chin, don't think that we depend 100% on the adaptation. We use surgical maneuvers to help this adaptation. It goes from the intra-op. When we are finishing the surgery, the stitches we give, they are not only to close the wounds, but they also to anchor the soft tissues and muscles to the bone. We call this anchoring sutures, stitches that go through the bone in strategic key points, okay? Also, as you know, after surgery, there's going to be a therapy called compression therapy with a chin band. The chin band is an elastic band that you have to use for at least 1 month, more constantly in the first week, but then in a more light way in the rest of the month. But that is also something that helps to put tissues in place. So the patient's own readaptation, because of their own collagen, their own age, our surgical techniques, and the post-op care is what's going to give the best possible results regarding tightening and readaptation.
Do you guys use a Fraxel or Pixel laser?
No, we don't. We are now we have now been working with establishing treatments with laser, but in general for incisions, for example. But we're not been working with laser for the skin.
Just for the edification of the people in the crowd, there's a laser that we use very commonly in the United States called a Fraxel or Pixel, and I've had it done. I had terrible acne, horrible acne. I had to take Accutane a bunch of times. And it fixes the pitting scars, but the way that it works is it effectively burns a grid into your skin, and then the grid that's burned in, those cells are dead, and then they sort of purse string around the hole that was burnt by the Fraxel, pulling the skin a little more taut. And so it's been utilized for skin rejuvenation, along with CO2, laser ablation and stem cell transplantation, all kinds of other stuff. But I was curious if you guys mess around with the laser things or not yet.
We don't, because we are so focused. Maybe someday we're going to go to that, let's say, stage as well. But we are so focused nowadays with the structural surgery that we avoid doing any other parallel procedures that could increase inflammation from the surgery that we are already doing. So we are not doing facial peelings. We are not doing small cosmetic treatments of the face. We are really focused on the structure. Maybe at some point we'll add other parallel procedures like this, more for cosmetic reasons, but they should be performed on a different time, not at the same stage as the facial surgery.
Exactly. You guys have the same problem that I do, is that you have more patients than you can possibly see. And so like adding on an additional thing right now is just not happening, because I have, my waiting list is like 700 people, I think now, maybe 750. Like you guys are in the same boat when you're that popular that like you can't. People are like, when are you going to be doing it? I'm like, I'm not. Like, not until I have other people. So like, I think maybe as a long term, if you guys had an esthetician or some other services you could offer out of, FS, would be great. But I understand the situation with Facialteam is that the demand for you is so high that you probably barely even get to be around your family.
On that topic, I'd like to make a comment, because I think it's also important to stay focused in one area, because if you start to disperse your focus, then it's taking away energy. It's not possible for you to have energy for everything. So I think
exactly. I mean, it's if you look at our current team, Dr. Powers, we have been, of course, we have been doing this for many years. So we have been approached for so many type of different ideas, like, why don't you guys offer HRT? Why don't you guys offer SRS? Why don't you guys do body surgery? But I mean,
because we're Facialteam.
We're a Facialteam, and it's we believe this is our vision. The vision that we think that a specialist that is doing a procedure that is so important in the life of these patients should be so highly specialized in that procedure that it's not possible that you can do many things at the same time or disperse your focus. I think the word here is really focus. And if you can be focused, not only you can do the surgery well, but you can evolve. I don't believe that we would be able to have had the evolution we had. We are now a different Facialteam than we were in 2011, and I don't believe we would have this evolution if you would be a sparse attention, because we are doing also SRS, or we are doing breast augmentation and cosmetics. So it's a work philosophy that we believe is working for now.
It would be multitasking, being a jack of all trades and master of none.
Yeah.
I know the feeling. I often joke about there's a show that's called Adventure Time, and I posted a thing to my Facebook page a while back about it. But there's this episode where there's this cat, and he calls the main character Finn, like Frank the human boy, and he's like, what? That's not my name. And he's like, I have approximate knowledge of many things, and that's how I feel as a family doctor. I have like approximate knowledge of every field of medicine, and that's my job, is to be the jack of all trades. I don't really have as much of a niche as you guys do, but then I guess I kind of carved one out for myself.
Yeah, but when we began, we didn't have 100% focus on FFS. but it was a growing thing. Of course, at some point we could choose, okay, let's keep doing everything, or let's go and focus on FFS. The decision was there. We didn't know it was a right or wrong decision. We heard that we were crazy. We heard from colleagues or friends saying that you shouldn't do that. There's so much of a scope you can do a lot of things, but we chose to do this, and I don't regret the decision. I think that professionally it has made us very, very happy to be able to evolve like this.
Your reputation precedes you, so I think you guys made the right decision.
Thank you, Dr. Power.
I think we've been going for about over an hour and a half now.
Wow.
So we're going to round up. There's a couple of questions that I want to get out there before we go. Okay, yeah. But this is fantastic.
If anybody has a question that I didn't answer or we didn't get to address, post it on my subreddit. I'll make a post after this for like responding to them, and then you can post on the subreddit, and then I'll try and reply to everybody's individual question if I can in that post. It's the subreddit's Dr. like Dr. Will Powers. That way I can kind of catch up.
It's amazing. You're everywhere. The subreddit is incredible. There's a lot of information on there. I highly recommend everybody to check it out. If you're not on Reddit, it's very easy to join. So Dr. Simon, there was a question. Does Facialteam do type 3 cranioplasty?
Yes. It's an interesting thing as well, because it's a little bit of a, let's say, a rogue. Facialteam was a rogue when we started, because we really don't work with this classification of type 1, type 2, or type 3, because we don't believe very much on type 2. Type 2, it would just be more of a combination of working with shaving of the bone and adding bone cement or adding a bone substitute, okay? So we have two types of forehead, and the foreheads that are for any reason, which is not more than 3% of those foreheads, which are foreheads that has no frontal sinus, an absence of frontal sinus. It's rare, but it can happen. In those foreheads, if the amount of bossing is not very strong, we can work with only a bone shaving, because you're going to shave, and wherever you go, and it can get to the maximum level, which is the perfect transition between forehead and nose, you can get there without doing a type 3 or a reconstruction. Good. But this is not more than 3% of our cases. So 97% will have a big frontal sinus or a small one, doesn't matter. And in those cases, it's much better to work with a reconstruction, because when you do a reconstruction or type 3, you are always guaranteed that you are going to reach the point of success, which means for us, smooth transition between forehead and nose. So a forehead reconstruction is not something that is dangerous. Most patients are worried about. It's the opposite. It's safe, because we are let's say, we are completely sure that we are protecting the frontal sinus, that we are going to leave an anatomic closure to the frontal sinus, that the final result is going to be the one we want to have. So forehead reconstruction, it's a revolution. I think that working with this type of technique just gives us a lot of freedom during the procedure. So yes, we work with type 3, let's say, but we prefer to call forehead reconstruction.
And just one more for you, Dr. Simon, on the same topic. Can you comment about redoing FFS do-over, specifically in the forehead contouring area and the scalp line scar from the scalp eyebrow surgery where they have a bad scar?
Well, as you know, when you're doing forehead surgery, a first one, there are different techniques that can be used. Like I said, some surgeons are going to do shaving, some surgeons are going to do reconstruction, but also there's different types of incisions. The incisions can be on the hairline, they can be inside, it can be a mix of them. So when we are talking about redoing, in general, we face our situations where we have to evaluate not only the result, but also where was the scar placed. Is there a functional problem, which happens many times? There's an infection. It's not only about a result of the shape, but it's also an infection. So redoing in general, we need to see if we have to address the scar again. If it's a surgery that has been done through the hairline, which we really rarely do, we will work with our normal incision. So we are going to do an incision, a coronal approach, hidden inside the hair, and we will normally use a simultaneous hair transplant. So we use follicles from the same incision to reconstruct the hairline over the scar and make that much more natural. And then when we got to the bone area, normally you have two situations, or it's a suboptimal result. So let's say a surgeon did a shaving, was poor, the result was not enough as patient wanted, so we just go and complete the surgery. Or the more complex cases that happens, I think, more often than the suboptimal. The thing that we see the most are results that are too aggressive, leaving bone defects. In those cases, we have to expose the area and reconstruct it. In general, we will use bone grafts from the patient, from the same area of the head. So we can design those bone grafts according to the size, to the area where we have to reconstruct. We can obtain those bone grafts only using ultrasonic technology. So there's no burrs cutting through the skull. These are all ultrasonic instruments that cut bone in a very safe way, and we reconstruct this. So at the end of the day, redoing surgery for us is avoiding a visible scar. So if we have to cover, we cover. Restoring function to the sinus when it has infection, foreign materials like bone cement, even fat from the patient that is placed inside the sinus. Some surgeons, they want to obliterate the sinus, which means when they open the sinus, they want to put something inside so that the sinus doesn't work anymore. We don't believe in that. And of course, give the final shape. We want to do a surgery that not only function is restored, but do the best possible final shape of the forehead.
Can I ask you a question, Dr. Simon?
Yeah.
So as I joked earlier about my Neanderthal forehead, I've had a CT of my head a long time ago, and I have an absolutely massive frontal sinus. I mean, like you could stick marbles in it. And so would that be a concern in regards to, like, does effectively opening it to the soft tissues in front of it run an increased risk of infections or complications, or does it not really matter?
No, it doesn't matter. Having a big sinus, it doesn't change the result of the surgery. With the techniques that we have nowadays, it doesn't matter the shape of the sinus or how big it is. We'll always be able first to get to the ideal result. Now, the fact of because we work with different things, it's not the bone only. We can sculpt the bone. We have titanium meshes that we use to complete some areas. So the result is always going to be really good. In a case like yours, we can do a very, very strong result. But the fact of exposing the sinus, this is not a problem. We are only seeing a sinus during surgery. The sinus, if you start fooling around with the sinus and trying to obliterate the ductus that goes to the nose, trying to put things there or bone cement, then it can have problems. As you know, there's another type of surgery that is much more performed around the world every day for many years, which is called orthognathic surgery. And orthognathic surgery, the surgery that is done on the upper and lower jaw to move the jaws when patients are like this or like this. Okay, so in those surgeries, 100% of the time you will have to cut on the upper jaw and you expose the two maxillary sinus. But you expose them not only very largely, but you expose them to the mouth environment, which is potentially contaminated. We have bacteria on the mouth. There's no reason, no maxillofacial surgeon is obliterating that sinus or trying to do something. You just open, you leave it very clean, and you close it, and it's going to heal very well. This is our philosophy that we transfer to the frontal sinus. That's why we don't damage the frontal sinus. We don't obliterate it at all.
Thank you. I had no idea. That's new to me.
Yeah.
You're more than welcome to come sometime to Spain, Marbella, and observe the surgeries.
That would be very cool.
Yeah,
I love
it's very common.
In Madrid. Yeah. I would love to come hang out.
Vendrás a España a ver un poquito de cirugía.
Y practicar el español.
Sí, practicar el español.
Mucho. Cuando no usas un idioma, olvidas.
Bueno, a practicar.
So we're gonna round up now the questions. We've talked about a lot of things: HRT, FFS, when to start hormones, when to stop hormones, if you need to, switching. Thank you everybody for all your questions. As Dr. Power said before, if we haven't answered your question, we're sorry, and please do send them to us by email or contact him on his subreddit. So to close, I'd like to ask both of you, where do you think TNBI, trans, non-binary, intersex, and gender non-conforming healthcare is heading? And what advice do you want people take away from here today who can't access FFS with Facialteam, who can't access the Powers method? And some of these people maybe are considering silicone injections for feminization or considering self-medicating, doing the DIY thing. What are your recommendations for these people?
Dr. Powers.
It's an interesting question, and I want to make sure I answer it well because my answer is very important.
Specifically for you, Dr. Powers, they asked, how do I get the Powers method for me without DIYing?
The Powers method isn't like a thing. It's a living thing. It's not just like a dead piece of paper that you can just follow this algorithm, right? So the Powers method is effectively me adapting the care that I provide to individual patients to specialize it for them. You can kind of see the flow path of that if you go through my PowerPoint, but it is unique to everyone. So the Powers method that this guy gets is different than the one that girl gets. It's kind of, it varies based on the human.
It's not a cookie cutter.
I definitely would stay away from illicit silicone injections. That's a no-brainer, because once those are in, you can't take them out. You're stuck with that forever. That's not a good idea. But I'll say this, and I know this is not the same as gender dysphoria, but when I recovered from the fire, when I say recovered, I meant like I was sane. I had a lot of difficulty accepting my life. I had a tremendous amount of difficulty accepting that my cats were dead and that I had lost everything and that me and my wife were so disrupted and that we'd just been through hell, right? And I didn't like my new life. I didn't want to live in it. I hated it. And it wasn't until I kind of came to peace with it and started to look forward to the good things that I could have in my new life and stopped yearning as much for the things that I had lost that I really experienced any sort of personal growth. And I know when I say that, it kind of comes across as like, don't focus on your gender dysphoria, focus on something, which is like, yeah, okay. It'd be like telling me the days after the fire, don't think about the fact that your cats died. Like, you can't. But at the same time, the advice is still good advice, because I didn't actually start to get better until I started to focus on other aspects of my life that I could improve, and myself and my personality and my mental health and everything. It wasn't until I actually did that my life got any better. So while you're stuck with the gender dysphoria, you're not stuck with your situation. You say, I can't afford to go to Spain. Well, then why? Well, work on that. To go back to school, get a better job, improve your socioeconomic status. I mean, I'm not very ashamed of this, but I tell people all the time, at 14 years ago, I was in Pittsburgh after I got back from Spain. And my dad, to his credit, I appreciate it now, said, you're on your own, son. You can't live here. And I had $100 in my bank account. I ended up sleeping in my car for like 2 weeks till I could figure out a place to live, and, you know, got a job and worked my way. And like, literally, it was rough. But I dug myself up from that to where I am now. And so I would say effectively that don't let your dysphoria and your current situation dictate your future. Because if you really want to get FFS with Facialteam and you can't afford it, then figure out how you can afford it, how I can improve myself, how I can get a better job, how I can lift myself up, like clawing up from nothing. I mean, I literally was living out of a broken down car for weeks. And here I am, you know, I own Powers Family Medicine. So like, that was 14 years ago. It wasn't even that long ago. That'd be my advice. Don't stick silicone in yourself to get some like DIY half-assed thing. You're going to regret it in the long run. Try and direct the energy and your frustration and your anger at yourself of the like, why do I have this body? Direct it at, how do I make it better? How can I improve the situation? Because you need you need someone to help you with the hormones and the other stuff. But to get to that point, there are many other things in your life you can do. And it's only through that, well, my name's Will Powers. I'm probably appropriately named for what the universe has thrown at me. I mean, it literally keeps trying to put me down. If you look at my Facebook, like I'm almost gotten killed a few times in the past few years, and I just keep coming. I never gave up. I never gave up. I never give up on anything. If I set my mind to something, I will literally do it forever until I succeed. I will fail and fail and fail. So I guess in summary, think about your life not as I'm a failure, but I failed right now. Right now I'm failing. How do I not fail? How do I do better? How do I improve? How do I get myself in a better situation? How do I get a better job? How can I make it so that I have the money to fly to Spain and see Facialteam, the best in the world, and get FFS? How can I fly from Sydney to Dr. Powers in Detroit so that he can give me the best HRT out there? And that answer doesn't have anything to do with being trans. That answer has to do with just being a human being and having to play this game. I'm at level 35 currently. You know, I've been playing it for a while. I spawned on the North American server, and I've been doing my best to, you know, acquire loot and reputation with my guild here. Like, no one knows why we're here. You just are. Like, one day I woke up and I was like, I'm alive. Okay. And I always tell my patients, like, a gamma ray burst can come from a local neutron star at any time. Boom. Hits the whole planet, wipes the entire planet out in an instant. Every living being on Earth is dead. and it comes at the speed of light, so we wouldn't even know that it's coming. That can come anytime. Now, five minutes from now, life doesn't have intrinsic meaning to it. And we like to think that it does. It doesn't. You have to find it for yourself. So for me, that meaning has been helping these people. It's the reason I kept going after the fire, was that they told me that they needed me. For anyone else watching this, find yours. Like, find what your thing is that gives you joy and allows you to escape from dysphoria. And use that to build yourself up so that you can get access to the things that you want, so you can have a happy life. And then when you get to the point where you're like, I'm not doing too bad. Like, I feel right now like I'm doing okay. Pay it forward. Help other people. Reduce suffering. It's the only thing I've ever found that does anything to help me with the absurdity of being in this universe. Help other people. Pay it forward. Try and live a happy life. Sorry, that was long.
I think there's some pretty solid advice.
That was very nice. Yeah.
Solid advice there, Dr. Polaris. And that, you know, they're not alone. And everybody has their walls that they have to get over in life. And privilege is a thing that makes it easier for some and more difficult for others. But I think what the last thing you said is very important, is to try to remember that there are people who need you, whether you realize it or not, people who love you and people you can help too. And even
Or animals. I used to run a cat shelter. That gave me joy after the fire, to take care of the cats. It just was a thing. I reduced their suffering. Help animals. I mean, there's so many things you could do. It's what I do with every patient that comes to me that says they're going to commit suicide. Like, I'm done, Dr. Powers. I can't do this anymore. I'm done. I'm like, all right, cool. Well, we're going to set you up with a Peace Corps then. And they're like, what? And I'm like, yep, we're going to get you set up with a Peace Corps. We're going to get you shipped off to some country in Africa, and you're going to dig wells. And they're like, why? I'm like, because you're a living, breathing human being, and if you're going to waste it, at least do me a solid and help these people over here dig a well before you check out. And I've had patients go. They actually go, and they do it. And they come back, and they're like, I found a reason to live. I care about these people now, and they needed me. I had a purpose. I literally pumped them to the Peace Corps when I've tried everything, and I just can't get them out of a depression. I'm like, fine. Like, it's like rolling a 20-sided die. Like, you just start over. Like, the worst you can roll is 1 if you're already at a 1. But I send them to the Peace Corps. It gives them a purpose to live.
That's very interesting. Yeah, in the 10 years that I've been working with the trans community, and particularly on social media, where people feel more liberty to, you know, express these kinds of feelings that they're having. And so all the time people are like, I just want to kill myself. And yesterday on Reddit, I was answering one of these, and I just tell them, you know, please don't give up, and try to send a positive message, and encourage them to keep communicating with the rest of the community, because we're all here to help people, professionals, the rest of your peers, which is why I created the peer group on Facebook, which now has over 3,000 members and is going strong now, 8 years. And for many of these people who, you know, reach a point where they're like, I don't know if I can continue anymore. You have to.
Whenever I feel despair, which unfortunately in the past few years, I have spent a lot of time in utter despair. And whenever I feel despair to the point where I'm like, I cannot do this anymore. I'm exhausted. I can't do this anymore. The reason I carry on is them. That's what I do. I find a reason, like, it's them. I help them because I know they're suffering. And doing that, I literally get on my computer and I start messing around with PowerPoint for version 7, or I answer people on Reddit. And I do something so that I feel like I helped somebody, because they're suffering, and all I want in the world is to not be suffering. Like, I have this crushing pressure in my chest to not feel the grief that I feel over the various terrible things that have happened to me. And I do that. And that gives me, I don't want to cry, but like, it gives me some purpose and the feeling like I still matter. Like, there's a reason for me to keep doing this game. Like, none of us know what happens when we die. No one's yet come back to tell me. So like, maybe that's it. You're done. Maybe you take the helmet off and like the Rick and Morty arcade and be like, whoa, that was crazy. Let's do it again. Like, no one knows. So like, that's the only thing that's ever really helped me. is that when I just felt utter despair, was to find someone else in despair and help them, and hope that eventually the karma train will come around and someone will do it for me. And it did. They did. That day when I was out behind my house, they came and found me. That was the karma train coming back around. It was the people who I'd helped who were there to literally lift me off the ground and get me to my feet.
Wow, that's amazing.
So it's just important that everybody understands that, like, dysphoria sucks. I even got to experience it briefly. I ended up dosing myself with a facial cream. I grabbed the wrong one. I grabbed the 10% estradiol instead of the 1% estriol. And yeah, I knew I had screwed that up after about 24 hours. It was awful. Absolutely awful. If I have to live like that, oh my God. I'm glad I had the experience, but I'll never make that mistake again. So I don't want to tell people that I don't know, but I do know what chronic pain is like, living with something that is just either psychological pain or physical pain, and there's no escaping it. So if you can't escape it, there's no way you can just discharge this dysphoria and you don't have access to it. Help other people and improve your own life. Improve, like, this meat sack. Like, we're all just thinking meat, right? We're just meat that, like, is able to think. Improve your meat sack in other ways. Work on your physical fitness. Educate yourself. Learn a skill. Go back to school. Get a better job. Make more money. Fly to Spain. Get FFS. Like, that's where that ends. And depression makes people get stuck in that loop. They can't. It's just, oh, I can't because of this. It's just another obstacle, another obstacle. And it isn't until they can literally break that loop and say, okay, how do I get to Spain to get FFS from these people? And I live in whatever, Laos. You know, they're living like a third world country. They have no access to all these things. Like, they have to, like, okay. And I literally had this, I didn't get into medical school the first time I applied. I was rejected. And I had spent that year saving up money to apply for the application fees. Thousands of dollars. I worked at this job I hated when I was, like, living in a kid's closet. Literally, a closet is what my bedroom was for a while. And I got rejected. And I knew that I didn't get to go that year. So I literally had to do it again. So I had to wait another year and save up the money again to do the application fees a second time. And I got in the second time. But I didn't say, oh, I guess I'm not going to be a doctor. I was like, nope, okay, well, guess I'm doing this for another year of my life. And that's exactly what happened. So
on the topic of mental health, I'd like to ask Dr. Simon how that works with our patients. And we have a counselor on our staff who helps people.
Yes, we have Marina. We have a psychologist in our staff that have been working with us for some years now. She's an in-house psychologist, giving support to the patients before surgery, during the stay in Marbella, and after. She also gives group sessions for the patients that are in Marbella. It's very important. And I would like just to comment, Lilia, on what Dr. Powers was saying. No, I mean, when we started Facialteam, and I could say now that when we put together my minds with my partner, with Luis Capitan, and we have now a vision that what we want to do is to make lives of transgender women better all around the world. And it's not something that it's not a strange vision. It's a real vision, because if you look for that vision, everything that you do is going to get you the fruits that you want to get, but it's also going to help them a lot. So we are a team of a lot of surgeons. I mean, we are now almost 6 surgeons now. And if you count the hair team, we are a lot of people. And we are not able to operate more than 300 patients a year. How many millions of trans women need feminization surgery? So what I can say to patients is, first, before you think about having any kind of surgery, before you think about costs, which is something that you probably see this, right, Dr. Powers, that a patient is already, let's say, sad about not having the surgery with us or with other center because of the cost, and they didn't even have an evaluation. Okay, so first thing that it's important is that you should have an evaluation with us or a center that is specialized with FFS. An evaluation with Facialteam has no cost. And this evaluation is very important because it puts you down to earth to understand what is that you need on your FFS. You may be having in your mind that you need a big amount of procedures, and then when you do your consultation, you understand, wow, I just needed maybe just my forehead, or just my forehead and my Adam's apple.
This is already powerful because this can change completely, dramatically, the perspective of costs, okay? The second thing, it's important, an evaluation like this is going to serve to you as a guide map, because even if you don't have surgery with us, you will understand at least the procedures that were presented to you as the best ones in your case. So if you have surgery in Laos or in China or in America with another surgeon, you will have already your own tools to discuss with your surgeon. You are not going to be just thrown on a treatment plan that is not ideal for you. So I think this kind of information is very important. So use those Skypes that we offer every week, and we do it with a lot of pleasure, where we can discuss with every patient what they need, and we try to establish a plan, and they understand at least what is the guide map that they should follow regarding their face. Okay? And what we do to help patients that maybe will not get to us at some point, of course, it's spreading the knowledge that we have achieved by doing scientific publications, as we are doing. Many surgeons are operating nowadays around the world because of the publications that we have made public. We have been doing our training programs, doing training programs not only in Spain but also in America, for example. So there are now more and more surgeons that are starting to use methods that are scientifically proven, methods that are precise, methods that do not require so much of artistry. When surgeons talk about feminization being pure artistry, this is when you should be a little bit more concerned, because if a surgery depends only on artistry, then you really will have just a small amount of people to do your surgery, and it's not going to be with Facialteam, because we are not artists. We are surgeons that have our abilities with our hands and try to use everything we can with science to make precision, to make predictability. And if you depend on artistry, you are going to be looking a lot for some Picassos or geniuses that we are not. In Facialteam, we are not geniuses here. We are just surgeons that are trained a lot doing something many times ago, again and again, and became good at it. Okay? So this is my message. Don't lose, of course, your hope, but don't, before thinking about what is that you cannot do, what you're missing, get a lot of information, and we offer that information for free, even for patients from Europe that they come to us for a consultation in person. Maybe there are some in the group here that did this, can confirm. We don't charge anything for you coming to Spain for the consultation. We do a CT scan, we do a simulation of the result, and a full treatment plan, and this has no cost. It's our work for you to have your guide map and your orientation. So this is my message.
Did you say you do a CT scan?
Yeah.
For free?
For
people coming for a consult?
Any patient, yeah. Every patient that comes to us.
I don't know if the people here realize like what that machine costs and what it costs to run, like, just so it's clear to the people that are watching this, that's literally like just taking money and just burning it. And they're like, I can't believe you do that. That is so incredibly kind as to be ridiculous. Like,
but it's part of the vision.
Like, it's ridiculously kind thing to do. I mean, I've been just more and more impressed with you guys, and I understand now why people wanted us to collaborate. Like, it's really starting to click for me, because we both give a shit. You guys really care. Like, you really care, and you really just want to help people. And that's why you're so focused on what you do, because that's what you're best at. That's your thing that you can do. I can't believe you do that. I've never even heard of anybody doing that before in any situation anywhere. It's.
We pay for the taxi too.
I take a couple charity cases now and again, but I'm not handing out free CT scans. That's a whole other level of like, it's $1 million machine.
Yeah, but again, it's we have a lot of belief. I believe a lot on the fact that the treatment plan is a game changer for patients. And because, as I told you, patients come with an idea that sometimes is completely out of reality. And when they see the skull, when they see the scan, they understand very well what's happening. Most patients that we have, and they come to us and they have surgery with other centers. Sometimes the other centers, they do maybe an X-ray, not a CT scan, an X-ray. And the patients, they have more information than the surgeon. They say, well, but I was a Facialteam, and look, I have a 3D scan showing my skull. So, I mean, you have to give all this information to the patients, this is one of the things we believe it helps a lot on the process of decision.
You guys are great. I can't wait to hang out with you.
More than welcome to come, as I said before.
Yes, we wait to hear.
Your doors are open. Our doors are open. So I don't know if we'll make
my cats if you come. I can offer you that.
I've always wanted to go to Detroit.
That's what everyone says. It's not as bad as they make it out to be. It's actually gotten a lot nicer lately. I'd say over the past few years, things have really improved a lot. There's a lot of revitalization going on downtown. It's not exactly the Mad Max sort of scenario that's portrayed in the media.
I'm interested in the cultural history and the community. I think it's very interesting. The art, the music. So,
there's a lot of really cool museums here.
Someday.
Let's see next year. Yeah.
We'll see. So we've been going for 2 hours now, and it's incredible.
Yeah.
We still have over 100 viewers watching. You guys are amazing. Thank you so much, both of you, and for our viewers. And
thank you, Lilia.
Let's give a hand here, everybody. Let's see your claps. The people are still here. Give us some claps. Thank you to also, again, to certain community members, you know who you are, who connected us with Dr. Powers and made this happen today and helped us to raise the right questions so that your input and lobbying are very important. So please do keep talking to us. Let us know what your questions are if we didn't address them today, and we'll try to get them answered by email or in another live in the future. Stay tuned for upcoming lives. On June 4th, next Thursday, we have Dr. Marcy Bowers, and on the 10th, the following week, with voice specialist Christy Block of New York City and Crystella Antoni of London. Also, don't forget our newsletter. Please do join us. The link is right down there below. Just click on that, join our newsletter to keep up to date and always be notified when our lives are coming. And finally, we want to provide the content you need. So please do send us, again, your feedback and comments. Stay safe, stay healthy, because your health care really does matter. Don't forget that. Thank you.
My final message, Lilia, if I can, is just this, that we are very happy on doing this type of initiative where we put together professionals from around the world. I think it's an opportunity for us to meet, but also for the patients to watch different professionals from different backgrounds. We have been doing this from 2013, 14. We have had meetings with Dr. Precha, Kamal, Suporn, Monstray, Bowers, McGinn. Well, it's so many people that we have been trying to have collaborations and work together, because we are isolated and we are working now in a world that it's so easy to connect. And these lives that we have been doing, they have been something new for me, particularly. We developed this during the coronavirus period, and I believe that this is something that's not going to go away. So some things come for good. We are going to change a bit the communication we have with the patients. We try to be very institutional, very serious every time, but I think lives like this should be more often, even after the crisis or the virus goes away. So I'm very happy. Very thankful for Lilia. She's showing to be like our David Letterman. So she's like really good at this. I didn't know she was so good at this. And so thank you so much, Dr. Powers, for participating here. I'd like to hear a message, but it was an amazing live, really amazing. And I hope we can do more things and talk again in the near future.
I would be thrilled to do that. I have to say, this was surreal. When you drop names like that, it's like people who are like my heroes. So it's like standing among giants. You know what I mean? It's weird. To even be here is kind of weird that you guys like want to talk to me. So like, that's pretty cool. I don't know. It's very flattering. I appreciated it very much. The fact that I got to do this was very cool. I would be thrilled to do it again. I am going to make a post on my subreddit momentarily. That's more or less going to be an AMA from this. So anybody whose question didn't get answered, I'll do my best today to get to all of them. But I don't know what else to say other than I'm immensely flattered to have been invited to do this, and it feels weird to be like talking to you guys. Like, I don't know. It's strange. I appreciated it very much.
Thank you so much. Thank you so much, really.
Thank you, everybody.